muscles that should not get tired, and we talked about this before, I hope. What happens is that there are some autoimmune disorders, such as like myasthenia gravis, right? People can have issues with, maintaining their acetylcholine levels so that the stuff, the muscles can still respond to the nerves. One of the earliest areas in these patients is going to be their eyelids, because we use it so many times a day. What its job is that to clean the, front of the eye. It's almost like those, your tears are the windshield, fluid that you can skirt on, right? And then the eyelids are basically those windshield wipers that really goes around several times a day to clean up the front of your eye. What happens is that tears, right, has to come from somewhere, and they come from the lacrimal gland. As you can see, it has a perfect anatomical arrangement, because lacrimal gland sits here, and it releases the tears. It's going to go through in front of the eye, and then, well, I don't want to constantly have tears coming out of my eyes, so you have to have a way to collect them. What's going to happen? You are going to have the superior and inferior canaliculi collects the tear and then gets into the lacrimal sac, and then the lacrimal sac will continue in the, posterior aspect inside the nose, and then it's going to empty itself as a nasolacrimal duct, and you're basically going to swallow it. Sometimes what happens in pediatric patients, they are born with these nasolacrimal ducts not necessarily completely open to the bottom, right? And then what's going to happen? Usually it happens like unilaterally, just one side. This baby is constantly as if like tearing all the time. In all reality, we all do that, but you are able to clean that up and swallow it so you don't see the entire process. But if the duct is closed, then the tear has no place to go out, so it's going to look like that they are constantly tearing down. What needs to happen? You wait about 6-8 months or so, and then surgically go in, and then stick a probe in and try to open these channels. And then basically, usually one time go is fine. If not, you can do it again. Give it a couple months to heal, and then try it again. But it's an easy fix. So anyhow, the lacrimal apparatus continuously bathes the eye to remove the airborne dust and debris, so that the front of the eye is constantly kept clean. One thing I want to say here, if you were to look into the books, that sometimes they talk about these two compartments, like anterior-posterior chambers, and then please do not confuse them with the sometimes they say anterior-posterior compartments, but it's not a good name because they both say anterior-posterior. One is supposed to be compartments, the other is supposed to be chambers. So I just want to tell you what I'm trying to say here. So instead of saying compartments anterior-posterior, it's better to say that there's an aqueous compartment, and then there's going to be a vitreous compartment, right? So the aqueous compartment is started on the front with the cornea, and it's all the way to the suspensory ligament. It's an aqueous compartment, meaning that it's filled with aqueous humor. And anything behind the suspensory ligaments all the way to the back of the eye is going to be filled with the vitreous humor, and now we call it as vitreous compartment. This is what I was trying to say. The anterior and posterior chambers are still found, right, in the aqueous compartment. But sometimes some books will call this as anterior compartment, and it makes it confusing. Anterior chamber, right? So please remember, anterior-posterior chambers are still in the anterior or aqueous compartment, right? That's what they are trying to tell you. What this is trying to say, right? The anterior compartment or anterior chamber, anterior chamber is behind the cornea to the anterior surface of the iris. So what determines the posterior end of this anterior chamber is the iris, right? And what happens is tiny little area behind the iris and all the way to the suspensory ligament, this tiny little area is the posterior chamber. And why should you care? Because what we'll say is that once the ciliary body releases the fluid, that fluid needs to go from the ciliary body and pass through underneath the suspensory ligament and replenish the aqueous humor, and then we will have a spot in the anterior chamber that's going to be kind of taken away back to the venous circulation. And this is the one that we can look at it together. So I'm sure you heard about when people have glaucoma, right? Glaucoma means that it's a increased pressure inside the eyeball. And it's very dangerous. Of course, why? Because if you have constant increased pressure, glaucoma, it's going to push against everything inside, and all these layers are so skinny and tiny, you're going to apply too much pressure on them. Eventually you can bother, right, the optic nerve, and once you lose it for good. You're blind on that eye. So you have to attend to it. And when you hear about glaucomas, they will talk about these open versus close angle glaucoma, and the angle is that they are trying to talk about right here, right? This is going to make the angle. What happens is that, as I said, the ciliary body will make the fluid, right? So the fluid will pass through, or it needs to pass through underneath the iris in front of the lens. So it's like a very skinny area over here to pass through. And then come to the anterior chamber, replenish this fluid, and eventually you have this canal of Schlemm that's like a, almost like a collection area back to the venous system, right? Scleral venous sinus. Remember those sinuses we talked about? It's basically some kind of a venous fluid we need to get back. Or I think one area we talked about was superior sagittal sinus, right? We took our CSF and tried to return it back to the venous circulation. So similar to that idea, this fluid is trying to get back to the venous circulation. So depending on this angle being open or closed, it determines how quickly this will deteriorate for the eye, right? So anyhow, what needs to happen, and it's a very tricky business because this fluid gets into the anterior chamber, but it also slowly seeps into the vitreous humor. So it has to be somehow like, think about this. It's an enclosed area, and you're constantly making a little bit of this fluid, right? So some of it needs to be replenishing the aqueous versus vitreous humor, but then whatever was in there already needs to be taken back again into the venous circulation. So the amount can be found in these areas always the same. A lot of the times what happens to people is that there are these canal of Schlemm get like obstructed. So there are these very neat surgeries that they do. They do these even like in Roanoke Caribbean Hospital. So they place these tiny little titanium tubes. They place it inside the canal of Schlemm, right? They insert the tube in there, and then they just leave it there for about 3 weeks time. And because this titanium tube is not, self, the body will come and try to get rid of it. So the fibroblasts will come to the area and cover this with a fibrotic tissue. And then after 3 weeks, they'll go back in and like gently remove the tube out, but it's going to give good enough, I guess, channel that you created from this fibroblast, and it's really the body's own system, so it's not going to fight against anymore. So it creates this nice little area, a hole, so it can connect it back again to the venous circulation. Yes. Oh, you don't want it to be normal, right? You don't want it open, you don't want it closed, right? But it can go either way. The idea is that if this is the angle, right, if it pushes too much, right, you have a large angle, angle right there, then what's going to happen, it's going to be much harder to pass underneath to come to the front, so it's much worse. Or if it comes closer to this one, now it freely comes here, but it's having hard time to come to the canal of Schlemm, so that's one not good either, right? But, yes. Yeah, it is worse. So if it gets closer, because it can still pass through, but if it cannot get to the emptying area, it's usually much worse. Yeah. Yes.
Wait, so is it just that angle, or does it change throughout the day?
Well, normally, like, you maintain it in a right angle so that the fluid can pass through to the anterior chamber, and also it can get into the canal of Schlemm, right? But for whatever reason, sometimes this, I guess, iris moves in a direction, gets kind of tilted into the anterior, I guess, chamber, and then what's going to happen that the fluid cannot reach to the emptying site. So I don't think it goes between back and forth, but what you try to do, remember a long time ago in renal fizz, what we were saying is that there are these drugs that you can use for glaucoma, right, to control that bicarbonate, carbonic anhydrase and stuff. So that's the enzyme used by those ciliary bodies. So what we try to do to slow down the makeup of this fluid by the medications we give, so that if it doesn't make too much, it's not as much problem for the patient, so that the pressure can be regulated like that.
So is it the ciliary body that's creating like the opening or
It has a role in it, but it's mainly the iris itself. Yeah, it can move, like if it's supposed to stay like this, it can move like that, or it can move like that, and there's like the lens behind it, so you can push it, everything accumulates in this little chamber area, or if it gets in there, but then the front part is enlarging, but it cannot drain itself, right? Yeah. All right. Anyhow, so I just want to get back to the certain layers of the eye and then talk about how the photons are understood by the photoreceptors. So if you were to look at the electromagnetic spectrum, as human beings, right, we have a tiny little area that we can see, right? In all reality, like Back to the Future kind of movies, what could have happened if you were to enlarge this into that, like you could see X-rays, maybe like infrared rays, radar, but we just cannot right now. Maybe we do, we don't know, right? We cannot really process to understand it. But within this tiny little range, we are going to have two types of photoreceptors, and they are going to respond to either dark or the color of this stuff. And then the color is going to be sensed by three different types of photoreceptors, and dark information is usually just one type. So the vertebrate eye has two major components: the optical part, right, as we said, to collect the information, focus it on the retina and understand it, and then the neural part, it's going to now take that optical image and change it into a neural code. Basically, the nerves in my optic center, in my occipital cortex, can understand it. I just want to say a couple of things about these optical components of the eye. What happens is that, on the next slide, I just want to show you, boards will commonly ask you that, like to see that if you can follow the layers, I guess. What has to happen is that if you were to bring a light beam in towards the eye, it needs to pass through this thin film of tears, right? We said in the outermost layer, on top of the corneal epithelium, you have to have these very skinny layer of fluid, basically, just so that all the dust and stuff coming when the eyes are open is going to be like collected by clean. And then I have the corneal epithelium, followed by cornea, the aqueous humor, the lens, the vitreous humor, then it gets to my photoreceptor. What are those tears, right? They are made out of the plasma ultrafiltrate. It helps bathe the cornea, keep it wet, and allow oxygen to, I guess, diffuse. And you all know, if you are ever like using contact lenses, the always recommended way, and I know they come up with these with like for teenagers, so you put it on sleep for a week, it's not a good idea, right? What you need to do, because behind that contact lens, a lot of protein accumulates during the day, that's why you need to take it out, clean it, right? Give your eyes at least overnight chance, right? So that they can, clean up all the build-up proteins on the cornea, like clean whatever it is, and then the corneal epithelium have a chance to, replenish itself. But what's going to happen, the other idea is that if the outside of the corneal epithelium, remember we said when people have like scleroderma kind of issues, right, they don't produce these tears properly, or what other example, like Graves' disease we talked about, right? If the eye is always protruding outside of its socket, right, you cannot really clean it properly, you cannot really maintain that layer of tear on top of it, so there's going to be more prone for like conjunctivitis, etc. Anyhow, the tear will have certain lysozymes and antibodies to counter infection, but of course to a certain degree. And then the superficial oily layer on it will slow down the evaporation, and then it's not going to spill from the margins of your eye, so it's going to be collected into the, those ducts that you can swallow it eventually. So if you were to follow a light beam, right, what this one is trying to show, it needs to pass through all these layers as we said, and at the very end needs to be focused onto the retinal layer. What happens is that if you were to look at these refractive indices, right, refractive indices of vitreous humor to lens to aqueous humor and the cornea are very similar to each other. So the biggest bending of the light happens between the light coming from the air and to cornea, right? So air to cornea, the biggest difference for the refractive indices is there. So the biggest bending of this is going to happen there. So sometimes when people have like really high numbers of myopia cases, like -7, -8, -9, right? Then what's going to happen? Their eyeball is really longer than others. So instead of being, I guess, perfect round, it's a little bit like concave shape, if it makes sense. So it's going to be harder for them, right, to maintain that bending. So it's going to add up, how they cannot see well. Usually, that high numbers of myopia will be like followed with astigmatism kind of issue. Anyhow, so just a couple of terms. What we said about accommodation, right? It's provided by the changing the shape of the lens, right? We talked about this. It's going to be held by the zonal fibers, and the capsule is stretched and relatively flattened. What's going to happen? The ciliary muscle fibers contract, and remember, when the ciliary fibers contract, they are going to release those suspensor ligaments, so the lens could become more rounded, right? Like this. And then increased curvature means increased focal power and shift of the focal point closer to the eye. And then what happens is that if there is accommodation, there is another term called presbyopia, and it's just a loss of accommodation with age. So after really you hit your 40s, like 42, 40, something like that, 43, 44, what's going to happen? A lot of these plus 40 people, it's almost like a sign that you are going to get these like reading glasses, because your eye cannot really accommodate properly anymore. Astigmatism is a different thing, right? It results from uneven curvature of the refractive surfaces of the eye. What does it mean? Again, all of these layers sitting on top of each other in very close like communication for the light to properly pass. What's going to happen? If one layer is more concave than the other, that they don't sit on top of each other. So it's different than where you focus your thing. So it's not like near-sightedness or far-sightedness. It's just that everything is blurred, right? So astigmatism is uneven curvature of the thing. Anyhow, so let's take a look at the retina and try to understand the physiology of the thing. This was the several layers that I was trying to talk about in retina. And please do remember, like when the light comes in this direction, right? When it hits the retina, it's not going to hit directly the photoreceptors, but it has to pass through all these layers, come to these photoreceptors. The ones you see here, cones and rods, are the ones photoreceptors. Once the light is understood by these cells, then you need to get rid of it, right? You need to dissipate the light, and it's going to be held by this pigmented epithelium, which is the outermost layer. Once the rods and cones process the light information, they are going to carry it backwards, right, toward these things called ganglion cells, and the ganglion cell axons will make up the optic nerve, right? So, yes. Yes. No, it was just showing something else, like the outer layers of these things. Are you talking about these? Okay, so light comes in like this. Let me show it here. Okay, so light was coming like this, right? And once it hits here, I'm right here, but it doesn't understand it right away there. It needs to still go down, and these are the cells will process that light. But it's almost like that sound information. Remember we said the vibration, once it's understood in the inner ear, you enter with the oval window, but you need to exit with the round window. You need to get rid of it. So once the light is understood, it needs to be, taken away. So this is the layer will take it away from these cells. And once they understood, they are going to process back towards the ganglion cells. And all of these are in like a very thin, and it says on the next slide, 200 micrometers thick. So it's very, very skinny. So all of these cells to plexiform layer, the inner layer, the outer layer, and then the ganglion cells, they're all going to talk to each other with these graded potentials. They don't even have to create an action potential. Only the ganglion cells will create action potential and send it away. So this one just shows like that. These tiny little arrows that I cut it from the figure was trying to show, and it's coming, what happens to these outer, portions of the rods and cones. So the light comes in, processed by these over here, and then once they release it, the light is going to be dissipated by this pigmented epithelium, or absorbed basically. Right? So that it's not constantly keep hitting the cones and rods continuously. Right? So as I was saying, the retina is very thin, right? So it has several layers, but very thin. So the important part are the photoreceptors, right? So what's going to happen, as I said, because it's such a thin layer, all of these cells from the bottom up towards the ganglion cells will talk to each other with the graded potential. The only ones can create the action potentials are going to be the ganglion cell layer, because that's the one is trying to carry this information to thalamus, etc. So as I said, there is rods is going to be the one responding to dark, and then cones are going to be responding to the light information, or they are going to process the colors as well. The one thing is really important, right? So sometimes when you are sitting down and looking at a certain object right in front of you, if somebody opens the door, even if you don't turn your head through, right? Somebody opens the door and comes in, you can still see it, right? But it's always the center of your gaze is very clear for you, but things on the periphery is not very well seen, right? And these slides are trying to explain that. So the central area of the retina is a small pit, as I said, called fovea, right? And fovea sits in the macular area. The foveal receptors are going to be having one-to-one bipolar cell communication, or the ganglion cell communication. Because of that, the center of my gaze is going to be very well seen by my occipital cortex, right? So this is what it's trying to say. If this particular cell, right, let's say cone, photoreceptor, is sitting in the foveal pit in my retina, whatever that cell sees is going to be given from one photoreceptor to one ganglion cell. So the ganglion cell perfectly sees what it is. That's why it's very clear. Remember that ganglion cell will take that information to thalamus, thalamus will give it to my occipital cortex, and I'm going to map it over there. Remember this somatotopic mapping we keep talking about for different things? Same thing is going to happen here. If the information, this photon, is not hitting the fovea, but it's hitting the peripheral part of the retina, bunch of these photoreceptors will be converging into one ganglion cell. That's why the things in your periphery is more fuzzy for you. You don't see them as well, right? Keep checking when I see it. Yeah, it's really true. Right? So physiologically, this is the reason how you see it. That's why if there's something on your peripheral vision, what you have to do, turn your head, bring that right central gaze to the object so you can actually see it more clearly, and then etc. Okay, anyhow, if you were to look at these photoreceptors a little bit closely, right, what's going to happen? They are going to have these outer segments and an inner segment. The outer segments have this very special arrangement, and the easiest way to understand that is if you have these like 25 cents, right, quarters, and you stack them up in a rouleau formation. You just stack them up on top of each other. Think about them like that. And you have several of these discs in the outer segments of these photoreceptors. And around these quarters, basically these discs, you are going to have these specialized protons. Those are the ones who like measure the light for you. Right? So, okay. It's going to happen. So if you look at them a little bit closely, you can see like throughout the disc membrane, you have these visual pigment molecules, basically the rhodopsin proteins, as we'll see. They are the ones going to see the information for you. The same for the cones, right, how they are arranged. As we just said, right, these are like the outer segments of these rods and cones. Outermost layer, we said, is this pigmented epithelium, and the job of that is to absorb the already seen light or photon information. What's going to happen? Some of these photoreceptors, if they need to be replenished, the outer segments can be like chopped out, and then the pigmented epithelia will digest, because there are a lot of phagocytotic cells in there. Important one is that this area is going to synthesize melanin, right, and transport and esterify vitamin A. So again, I'm sure you heard about it. The carrots, for example, are very rich from vitamin A, right? And if you don't have enough vitamin A, your vision is not perfect. Especially your dark vision is not going to be as good. It's trying to tell you this area, pigmented epithelium, requires vitamin A. If you don't have it, it's not going to be as helpful to your photoreceptor, so your visual information is not perfect either. So what happens to these photoreceptors, right? As I was saying earlier, for another thing that we were discussing this, remember? Under dark conditions, these photoreceptors will be depolarized. It's kind of going against the idea that, I think in sleep lectures, when we were looking into this, we had this one information about the thalamocortical communication, if you remember, right? Okay, so what it's trying to say, yes, under dark, these cells will be depolarized, right? So what's going to happen in the absence of the light? Sodium will enter to the outer segments of these rod, for example, through these cyclic GMP gated channels, and then it's going to depolarize the cell, right? And how the cell is going to stay at its depolarized state, or not, like keep going up and up all the time. Some of these potassium is going to leave from the still from the outer segment, but closer to the upper portions of it. So this constantly is going to happen during the dark condition. As soon as you give a light, it's going to close up these cyclic GMP gated channels, the sodium channels. If the sodium cannot come in, now this is a signal enough that these cells will start becoming hyperpolarized. So again, it's kind of like the opposite, because so many times once we give something like a signal, the cells would like depolarize for us. So it's the opposite way for the eyes. And this one tries to show that, right? If you were to give a light flash to the eye, like a signal, they are going to hyperpolarize. And it's going to take them some time to get back to their naive state again, right? That's going to be that bleaching idea that we'll talk about. What this one is trying to look at, right? If this is your photoreceptor and this is the outer segment having all these discs, if you look at the discs a little bit closely, right? This is the cell surface of that disc, and we have this protein sitting in it, right? This whole thing is called rhodopsin, and you see that there's an opsin protein sitting on the surface of these discs, which is found in the outer segments of the photoreceptor. If you were to look at this opsin molecule a little bit closely, it looks something like that, right? So it has a really unique, I guess, way that it functions. And then what's going to happen? Each of these rods, for example, will have about, look at this, 1 billion rhodopsin molecules. So it's very, very sensitive to the information coming in. And then what's going to happen? Within this opsin molecule, right in the middle of the membrane spanning segment, there's another protein sits, and it's called retinol, right? Remember from earlier chemistry lecture, if something is 11 or like something cis form, it's going to have a kink on its own. And in this sense, this kink in the 11 cis retinal form is going to be changing by the light hitting these areas, and it's going to change into all trans retinal, and the kink will move away. Why we call it sometimes that if you were to move from a very dark area, you open the door and walk into this very sunlight area, what's going to happen? You are going to have like a couple minutes of this bleached, kind of like, really the sensation of that bleach into your visual fields. What happens is that because all of your 11 cis retinals were hit suddenly by light, and then it changes into this one. And also why we call it as bleached, because the 11 cis retinal will have some sort of like a maroon color, and then once the light hits it, it turns into this all white transretinal form, right? So once this happens, this is a signal enough for these cells that it sees a photon, right? So, okay. Yeah, this is the one that I was trying to say. So 11 cis isomer is in this kind of like purple to maroon color, and once you hit them with a light, it turns into all trans isomer, and it's going to have this more like light white to cream color on its own. One thing that this process for this all trans isomer to get back to the 11 cis isomer form is going to take some time, couple of minutes, right? That's one of the reasons also when you, for example, enter a room all of a sudden, so think about the opposite. If you enter a room which is very dark, in the first minutes or so, right, that even though the rods are the ones who will see for you in the dark, the first ones to respond are going to be cones. But because their adaptation rate and how well they can see is not adjusted properly or genetically for the dark information, what's going to happen? You'll go into a dark room, and in the beginning, you don't see much, right? Maybe after a couple minutes later, maybe like 5 minutes later, you see that, oh, there's a table on the corner. Oh, there's like a chest of drawers on one side. And you wait a little more, maybe like there's a creepy guy sitting on a chair or something. But like, you see more and more. What I'm trying to say, the rods will take their time to adjust to that darkness, and then eventually they'll see better for you, okay? So this one just says that rhodopsin, once hit by a photon, it goes through like beta-rhodopsin, lumirodopsin, meta-rhodopsin 1, and then the 2. Then it goes back to all transretinal forms, and then all cisretinal, etc. Right? So it has to take the time to change itself back again to what it was. So this is really important, and explain on the next slide as well again. So after rhodopsin absorbs the photon of light, it activates many transducins, right? These transducins are basically G protein coupled receptors. So the alpha subunit of the transducin will be dissociating itself from the beta and gamma part. So it's always the same way, right? These G proteins work the same way. And then this alpha part binds and activates the phosphodiesterase, and the phosphodiesterase will hydrolyze the cyclic GMP. Remember we said cyclic GMP is needed to keep those sodium channels open, so in the dark, and the sodium keeps coming in and depolarizing these cells. If you were to activate this pathway, photon acts like a receptor for this G protein coupled receptor. The photon acts like a ligand for this G protein coupled receptor. Once it goes through its steps, right, the phosphodiesterase is activated and it hydrolyzes the cyclic GMP, so the gating on those sodium channels are not possible anymore. The sodium channels will close, and then the cells will start becoming, I guess, hyperpolarized. It's shown like this. So this is looking into one of those discs in the outer segments of the photoreceptor. We said that these rhodopsin molecule sits, and it has this 11 cis-retinal forms sitting inside of the entire protein. You bring the light information, 11 cis-retinal becomes 11 or transretinal form, and it activates the separation of this alpha subunit of the transducin G protein coupled receptor or protein, and then it's going to activate the phosphodiesterase, and it's going to block now the cyclic GMP, and that's going to start hyperpolarizing the cell, and this signal is now communicated to the ganglion cell layers, and they can take the information back to the occipital cortex. Anyhow, so it takes time to adjust to either light or dark conditions, right? And also the proteins have to go through this entire process. So as I was saying, the size of the pupil by the iris can change light sensitivity by about 16-fold. But you still need all of these photoreceptors to respond properly. During the dark adaptation, as I said, the first phase of the dark adaptation is going to be provided by the cones, so the first 5 to 10 minutes. But again, cones are not designed to see in the dark. The rods are just taking time to adjust themselves. After a certain time frame, they are going to see it much better for you. If you look at this, a fully dark adapted retina, relying on rods specifically, they are all completed their transformation, right? That they can have a light threshold that is as much as 15 times lower than the retina relying on the cone. So rods are very, very sensitive to the dark information. That's what it's trying to say. So what this is trying to say over here, right? If this is the relative light threshold and time spent in the dark, right? What happens is that cones will adapt to that light information very quickly, so they are not going to see for you perfectly, right? They have a relatively high threshold. But what has to happen, even if the light is very, very little, once the rods are adapted to that information, you can still see how you can get it right. Okay, this is what I was trying to say. In bright sunlight, rods will become ineffective because they are bleached, in a sense that all their kinks are turned into transretinal form. After returning to darkness, the rods will slowly regenerate the rhodopsin, and they will become sensitive again. That's the reason it takes time for you to see clear in the dark. This is just trying to show, right, as I said, there are going to be 3 types of cones, and they are trying to see the different wavelengths within that, I guess, light information, so I can see the colors, right? So S type of cones see the 420 nanometer range, and then M will see a little bit more, like 530 nanometer, and then you come to the L, it's going to see, it's basically like short, middle, and long. That's what it means. Different types of cones will see different, I guess, wavelengths to give me the color information. This is something we talked about earlier already, right? This is just to show ciliary processes of the ciliary body holding with the suspensor ligaments, the lens in place. What we said was this. Oh, there was a big arrow coming up. So it's just to show, right, the suspensor ligaments are taut, or I guess allow the lens to become more like stretched, or they can be contracted and then allow the lens to become more accommodated. Right? I thought I had just a couple other slides. Sometimes it's too long that I take them out. Yeah, okay. I'll show you the slide that I want to tell you about the like glasses and stuff. But anyhow, so this is all. Let's take a break and then we can look at the visual.